And now, it is my pleasure to introduce our honored speaker, Dr. Tim Brown. Dr. Brown is a senior fellow in the research program at the East-West Center, leading our HIV modeling team. His expertise in infectious disease modeling and its application to public policy has made him a highly sought-after thought leader by local media, especially on COVID-19. We here at the East-West Center rely heavily on Dr. Brown's expert advice to shape our COVID-related policies, and we hope today you'll be able to learn about the Delta variant and help educate others. With that, I'd like to turn it over to Dr. Tim Brown. Tim?
Thank you, Jill, and thanks everyone for attending. Let me share my screen here and we'll get started. Okay, this afternoon I'd like to talk to you about the Delta virus. All of you have heard more about this in the last couple of weeks, but in reality it's been around for some time and we've been learning more and more as time has gone on. All of you know the history of the COVID epidemic. You've lived through it in the last year and a half. For the first year of the COVID epidemic, the virus SARS-CoV-2 basically ran rampant globally. It pretty much ran without controls. We basically had to use extreme measures such as lockdowns that very often did economic harm. We did have other interventions, so-called non-pharmaceutical interventions such as masking, distancing, and those were effective, but the uptake of those was sporadic. People always kept wanting to go back to an unmasked state, to not have to distance anymore, to get back into large crowds. And as a consequence, we saw the virus continuing to reassert itself as the year went on. And then toward the end of 2020, modern science came to the rescue. Okay, we saw a new hope coming in the modality of the vaccines. In 2020, there was a radically accelerated vaccine development cycle. Basically, we saw vaccines developed in less than a year, which is virtually unheard of in infectious disease. In the past, vaccine development has taken typically 2 to 3 decades. In more recent years, maybe 4 to 5 years at least. Some vaccines, for example, HIV vaccines, have been virtually impossible to develop so far. But with COVID-19, we basically saw a vaccine developed in less than a year. No sooner was the sequence released by the Chinese in early January than over the next weekend, basically the first vaccines were actually designed and prepared. They were into clinical trials by mid-April, and the phase 3 trials, the much larger trials that are necessary for emergency use authorization, were in place by mid-July. And by December, we were actually seeing some countries already approving vaccines for emergency use. It was an amazing panoply of different types of vaccines using multiple technologies. We had new mRNA technologies that had been developed over the previous 2 decades. Delivery through adenovirus vectors, that is using other viruses to deliver the parts of the spike that were necessary to get the immune system ramped up. We saw inactivated or killed viruses, and we saw new technologies such as protein nanoparticles that are basically delivered to get the immune system going. And there was an incredible variety of these. This, for example, is from the vaccine tracker New York Times has, and we have 54 currently at the testing of safety and dosage state. At the other end, we've got 8 that have been fully approved, 11 that are in early or limited use, and 5 that have actually been given up because they failed in trials. But it's an amazing number of different vaccines and an amazing set of technologies that have been used. Now, the early studies of vaccines showed they had a real impact on people catching the SARS-CoV-2 virus. Studies on infection among those who were vaccinated were done, a number of these early on. They showed about a 90% reduction in infection. And this held up across a wide variety of studies. Some vaccines were a little less effective. For example, the Johnson & Johnson vaccine was only about 77% effective, whereas the mRNA, the Pfizer and the Moderna vaccines typically showed about 90% infectivity reductions in the field, 95% in the original trials. The reason they work is they lowered viral loads. Okay, with the older types of virus that were in the field, we were basically seeing the viral load drop. And the measure that we use of viral load is something called the cycle count. Okay, that's because of the way we develop the test. What we do is we amplify the virus. That is, we multiply it. So 2 becomes 4, 4 becomes 8, 8 becomes 16. Okay, that number of cycles that is necessary to get up to the point where the virus can be detected is known as the cycle count. If the cycle count is low, then it didn't take much amplification. That is, there was a lot of virus in the sample. If the cycle count is high, for example, 30 or 40, then you had to amplify it many, many times, so there wasn't much virus. And so the cycle count is kind of the inverse of the viral load. A low cycle count means high viral load. A high cycle count means low viral load. And what we found with the first studies of people who got infected after they received the vaccine was that, depending on when they got the vaccine, 2 weeks after the vaccine, they basically were seeing their cycle counts drop. That is, they were getting higher cycle counts, 27 instead of 25. That means their viral load had dropped. They had lower viral load than they did without the vaccine. So the vaccines were helping to prevent infections by reducing the viral load. Now, we had some early studies basically on how they affected transmission. That is, the vaccinated person transmitting virus onto another person. And this evidence was all before Delta came along. We primarily get this data by looking at secondary attacks in household members. That is, a person who's infected goes into their household. We see what percent of the household members they affect. And several studies found that basically what we saw was about a 50% reduction in transmission to household members among those who were vaccinated. It did not stop transmission entirely. And those who've been telling you that vaccines would stop transmission entirely, basically we're not really basing it on scientific evidence. The studies have shown about a 50% reduction. And this is one study, again, showing, this is the days from when the test, when they basically got vaccinated, and this is the drop in their effective transmission to other members of the household. And again, it levels off at about 40 to 50%. So we are seeing about a factor of 2 reduction in transmission from the vaccinated to the unvaccinated, but there is still some transmission. It's important to keep that in mind. Now, that decrease is due to the reduced viral load. This is a study from Israel of healthcare workers who got the Pfizer vaccine, and this was with the Alpha variant. And they actually looked at unvaccinated individuals, early vaccination, basically the week after, partially vaccinated, and then fully vaccinated is 2 weeks after they received the vaccine. And you can see the viral loads are much higher here and much lower over here in those fully vaccinated. Okay, and again, you see the cycle count here. Okay, again, a cycle count above, or I should say below 30 is actually, you can culture infectious virus from that. So basically that's kind of the cutoff that we normally use for infection. We say that if your cycle count is higher than 30, you basically are not transmitting. So you can see most of the people with vaccines, or a lot of the people with vaccines, are down here not transmitting. Some of them are still up here, which means they will be transmitting. On the other hand, in the unvaccinated cohort, most of them are up here with a high cycle count, or low cycle count, I should say, around 20, and that means they are very infectious at this point. Now, we also know that viral load variation is why we have super spreaders. If we look at the distribution, this is cycle count, this is the viral load, and this is the distribution of people. And so we see that a lot of people have a cycle count that's well above 30, which means they're not going to be very infectious at all. But there are a few people down here who have extremely low cycle counts. This is like 13. Okay, so they basically have a lot of virus, and these people transmit a huge amount. And these are the super spreaders. Okay, they're the people who have a very, very high viral load, and they can transmit. And what the study found was that 2% of the infected had almost 90% of the virus that was in the community. And that's where we see the super spreaders. And the other important finding of this study was that the viral load was independent of symptom status. The asymptomatics had almost the same viral load distribution as symptomatic individuals. And this explains one of the features of COVID-19, which is that we see asymptomatic people transmitting as much as symptomatic people. And that was very different from most other viruses we've dealt with before. Now, the really impressive thing about the vaccines was the impact they had on hospitalization and mortality. Okay, this was a sample of the first 4.7 million people in Israel receiving the Pfizer 2-dose vaccine. And after their second dose, we saw the documented infections drop. So those who got infected were reduced by 96.5% 14 days after receiving the vaccine. Those being hospitalized who did get breakthroughs were reduced by 98%. Severe disease reduced 98%. Deaths reduced 98%. This was the incredible success of the vaccines. They reduced illness and death immensely among those who had been vaccinated. Now, again, this data is all among pre-Delta variants. This was done in the early parts of the year when most of what was available or was seen in Israel was the Alpha variant, the so-called B.1.1.7. Now, with these vaccines coming out with these very, very high reductions in both people getting infected and also in illness and death, many thought the end of the pandemic was near. Okay, and we saw incredibly rapid vaccine approvals. These vaccines were approved in record time. Okay, fundamentally, we saw a whole number approved in December, and they were ramped out and rolled out in the countries very, very rapidly. A number of additional vaccines came along later, Sputnik from the Russians, Sinovac and Sinopharm from the Chinese. And everybody was thinking we would vaccinate our way out of the pandemic. But it's become clear now that getting 7.9 billion people vaccinated is very difficult. To date, only 28.5% of the world population has received even one dose of vaccine. And the virus has not just been sitting there waiting to get stopped. It's been busy doing things, okay? You've all heard of variants. A variant is a new genetic conformation for the virus. Basically, the virus makes mistakes every time it copies itself. And some of those mistakes lead to an improved ability to infect people, an improved ability to survive, for example, outside of the body, an improved ability to overcome our immune responses. Okay, and those are the ones that catch on and basically become the variants that we see in the wild. Now, the first one most people don't even know about. The first wave was the Wuhan strain that came out of China, and that's the yellow in this graph here. Okay, so this is prior to March of 2020. But there was a new variant called the D614G mutation that came out in the early part of 2020. And it took over the world basically in a matter of just 2 or 3 months. So this is the old variants. This is the Chinese variants in pink here. The purple here is the new variant with the D614 mutation. It basically stabilized the spikes, making it more infectious. It produced higher upper respiratory tract viral loads, but it did not produce higher severity or more deaths. But the global takeover literally happened inside a couple of months. So this is prior to March 1st. This is March 21st to 30th. You can see the blue, which is the D614G mutation, basically has pretty much taken over most of the world. Okay, and that happened literally in a couple of month period. Now, the next act was the Alpha variant. Okay, you've all heard of this. This is the variant that came out of the UK. Okay, now why are we worried about it? Watch this little movie here. This is showing you the spread of the Alpha variant across Europe starting in December. Okay, so starting here in November, we see it picks up in the UK, which is where it started, and then it very quickly spreads across Europe. And what we saw was we came down from the Christmas peak, but at this point then the Alpha variant was starting to pick up, and we saw the rapid growth of COVID cases across Europe. They were then brought down in March or so, basically because of lockdowns. So I'm showing you here Poland, Italy, France. You can see the impact that their lockdowns had in terms of reducing the number of new cases. But they had to use lockdowns basically to make that happen. The spread was wide and rapid throughout Europe. This shows you the proportion of cases within each European country that are the Alpha variant. So the red is Alpha, the other colors are different other variants. You can see it rapidly took over all of Europe. And so basically by the end of April, it had pretty much spread itself across Europe. And from there, it went on to spread to the rest of the world. By mid-May, it had taken the United States. Alpha is the B.1.1.7 variant. You can see here, we started with very little in February, and then you just see the rapid growth. And By this time in May, we were already at 74% alpha in the United States. So again, over a 3-month period, basically alpha took the US. Now, there's been a lot of time to study alpha. We know a lot about it. We know, for example, it's more contagious than the previous wild type viruses, about 60% more contagious. And that's why it managed to force those other viruses out. It produces higher viral loads and also probably attaches in a stronger way basically to the cells in your nose and throat. And that means it maintains more infectious material in those areas. It also potentially produces a longer duration of illness. There's some evidence of that. But the vaccine still worked very well against it. So basically, even though we had alpha out there, the vaccines were still effective against it. We're stopping transmission. We're basically removing the illness associated with it. But if you weren't vaccinated, it was found that it caused more serious illness. It produced higher mortality, and that was found in a number of different studies. And it spread in the absence of vaccination in most of the world. It spread across the globe by mid-2021. Okay, so by basically summer of this year, it pretty much had taken over most of the world. 43% of all the sequences in June were alpha. But it's not easy to keep your position on top when you're a virus. Okay, because first of all, in some places, humanity was pushing back. Okay, so for example, we were rolling out the vaccines very, very rapidly in the wealthier countries. So Israel, the UK, the United States, all basically rolled their vaccines out very, very quickly. You're all aware of this because you've lived through it in the last year. And what we saw in each one of those countries was the cases dropped very, very rapidly as the vaccines were rolled out. Okay. And at this point, remember, most of what we're dealing with here is the rapid spread of alpha. So basically, these vaccines are working very effectively against alpha and are bringing down the total number of new cases from the very, very high peaks that we saw after Christmas in most parts of the world. Now, that gave us the hubris to think that we'd won. We beat the virus. Basically, we can all go back to normal this summer. Okay, and that's what everybody was thinking until about 2 or 3 weeks ago. Well, not everybody. Some of us have been concerned about Delta since May. So let's look at what happened next. Okay, so the humans were pushing back. In the unvaxxed world, the pandemic just raged on. So this is new cases in the rest of the world. They continued at extremely high levels. And the cumulative cases were basically growing. Currently, they're at about 200 million on a global basis. So they've continued to increase even from this 160 million in May. And once again, as usual, human hubris is what kicked off the fourth wave. In India, Prime Minister Modi, after India had sort of put in place interventions, mostly the non-pharmaceutical interventions, masking, distancing, et cetera, lockdowns that we've seen used so effectively in many places. After they put those into place and they drove down the first wave in India, Prime Minister Modi got rather arrogant. Okay, and so he announced on January 20th that the country, which comprises 18% of the world's population, has saved the world from disaster by bringing the situation under control. Okay, as a consequence of that, the precautions got very lax because he told them it's over. The Indians have beat it. You don't have to worry about the virus anymore. He held massive election rallies in March and April. Sound familiar? We've heard that before. There was a massive religious celebration in April that brought millions of people to bathe in the Ganges and into a number of states in India. Unmasked, largely unprotected, super spreader events, major super spreader events that not only spread the virus, but they sent it back to every corner of India with the people who came there. And meanwhile, in India, Delta had been spreading. Okay, Delta was first reported in December of 2020, about the same time that we found out about Alpha. Okay, and here you see a graph that shows the takeover. The purple here is the Delta variant. Okay, these colors, the red here is the Alpha variant. It actually wasn't that dominant in India. Okay, there were other variants here that were more dominant. But what we see is as Delta started to spread here, this is like February, it basically very quickly took over to the point where it was almost 100% of the infections in India by the early parts of June. Okay. And what we saw with that, we saw this explosive growth of COVID in India. We all seen the news stories. We know large numbers of people died. It was a massive disaster. And the current estimates are that probably 2 to 4 million people died during this wave in India. Now, it came down, and a lot of that was basically having burned through most of the accessible population. But there are concerns now that it's coming back up. But we have a global economy. A virus in one country does not stay in one country. And Delta had changed the game. Okay, so let's talk about Delta. Well, Delta didn't feel like staying in India. Okay, it doesn't like that idea. It likes to get around. So from India, it had hot flights everywhere. Okay, so this is, for example, a wonderful little list that Canada maintains of people coming to the country on aircraft and their possible exposure to COVID on the plane. Okay, now they can do this because they did a 72-hour pretest. So they have everybody tested before they get on the plane. And then they do a 14-day quarantine on entry to the country, and nobody gets out of the quarantine. And they are tested during the quarantine. So if you tested negative on the pretest, but you then develop COVID in quarantine, they will know it. And then what they do is when they find people testing positive in quarantine, they post it to this website. So you can see the flights from Delhi here. And what it's telling you is these are the rows in the plane where they are saying, if you were in these rows, you have potentially been exposed to COVID and you better go get tested. And you probably should be quarantining. Okay. And so you can see huge numbers of flights coming from Delhi, lots of exposures. The worst case of this was one flight to Hong Kong, which was about 300 people, where they documented that 47 people on the flight had COVID at the time they were flying. So India basically, from India, Delta very quickly jumped onto planes and spread everywhere around the world. Now, in the United Kingdom, the scientists were actually watching for this. UK actually has a pretty good science establishment, and Public Health England does an incredible job on surveillance. Okay. Now, India did very little sequencing. So we actually didn't understand things from what happened in India because we didn't really find out about Delta until very late in India. But the UK did a lot. In the early parts of this year, they were sequencing almost 50% of all of the cases that they detect. Sequencing means we identify which variant it is. Okay, we go through, look at the base pairs, and we figure out, okay, this one's alpha, this one's delta, this one's gamma, this one's beta. Now, in mid-March, what they did was they were looking at the different variants that were coming in, and particularly they looked at India because they were concerned about what had just happened in India. And so you can see here, B117 is alpha. So yeah, there was alpha coming in the early parts of February and March from India. And that was the initial phases of the second wave in India. Okay. And then there was this B1617.1, which is kind of Delta's little brother, that basically came up, but it didn't go much of anywhere, kind of leveled off. And then there was Delta itself, B1617.2. And that one just kind of kept going. Okay. So they were watching it come in. The UK scientists were upset and were telling Boris Johnson's government that they need to rein in the travel, but Johnson didn't feel like doing that. Okay. Now they declared it a variant of interest on April 2nd, and they made it a variant of concern in early May. And fundamentally what they found was, this shows you again the proportion of viruses that are different types. Everything that's not on this graph basically is alpha, because alpha had already taken over the UK. But you see Delta basically started to take over. And it grew very, very rapidly. By the middle of May, basically it was up to about 10%. Okay, and they tracked this across the country. And some parts of the country saw very rapid spread, the Northwest in London, for example. And again, you see Delta taking over very, very quickly in these parts of the country. Okay, so Delta was really accelerating and spreading much more rapidly. Now, they also did studies of it. Because they do the sequencing, they can find out a lot about the virus. And they looked at attack rates within households. And again, they found that people with alpha had about 8.1% of their family members get infected. People with Delta had about 13.5%. That corresponds to about a 60% increase in transmission from a Delta infected person to an unvaccinated person than from an alpha infected person to an unvaccinated person. So a big difference. Delta was much more transmissible. And what we saw then was the cases I showed you before were coming down because of the vaccines being very effective against Alpha. But then the blue here is the number of cases basically of Alpha. The purple is the number of cases of Delta. So you can see what's happening is Alpha is still going down because the vaccines are working against it. Delta starts going up because it's much more infectious. And we'll also find because the vaccines are a little less effective against it. Okay. And eventually what happened was it reversed itself in the UK. Instead of continuing to fall with expanded vaccine rollout, the new cases started to come back up. But all hope was not lost because the vaccines, while they were less effective, were still doing a great job against Delta. Okay, at least in the UK, it seemed to be the case. They were slightly less effective. So the blue here is Alpha. The purple here is Delta. So you can see with those two of the Pfizer vaccine, there was only a very, very slight reduction, about 5% in effectiveness. So it dropped from about 93% down to about 88%. Okay, not much of a drop at all. This is the AstraZeneca vaccine, which was also the other common vaccine used in the UK. And there we saw a slightly larger drop of 6 or 7 points, but it was coming from a lower base of only about 74% effectiveness here. Okay, if you only had a single dose of either of these vaccines, you've got absolutely terrible protection, less than 50% down to about 30% with Delta. Okay, so these vaccines, single dose did not work very well. If you're single dosed with the vaccine, Delta can still get you is what it comes down to. Okay, so get your second dose if you haven't already. Okay, but even as the cases were rising, and this is the rapid rise in cases I talked about, it doesn't quite get as high as it did last Christmas, but it gets pretty close. And then it's fallen off recently, but again, that fall off is leveling off now. But look at deaths. This was the deaths due to, say, the 60,000 cases a day that were showing up here. There were over 1,200 deaths, 1,200 deaths a day. On the other hand, now, with everybody more heavily vaccinated in the UK, about 65% now of the population probably is vaccinated, the deaths stayed only below 100. Okay, so they're seeing far fewer deaths. This is the impact of the vaccines. They are preventing the deaths in the UK that we saw during the previous outbreak of Alpha early in the epidemic, even with Delta in play. And they are also producing far fewer COVID cases going to the hospital. Okay, so this is the number of COVID-19 patients in the hospital. It was above 35,000 back in December. Now it's about 6,000. It's not negligible. This is a lot of hospitalization, but it is far better than what it used to be. Okay. So the Delta variant is more easily transmitted. It reduces our vaccine effectiveness, but only a little bit. And it produces about twice as many hospitalizations as Alpha did. Okay. That's what we found out about it. But the vaccines have been very successful in the UK in reducing hospitalizations and deaths. What about the rest of the world? Well, Delta was just spreading like wildfire in the rest of the world. In the United States, this is where we left off on our previous slide with Alpha dominant here at 74%. Well, look at this little orange upstart here. This is Delta. It basically squeezed out Alpha real quick. Alpha didn't stand a chance. Alpha is now like 2.9% in the United States. Delta and its different variants is over 90% right now. Okay, and you can see the distribution across it. Alpha is hanging on a little bit here over on the East Coast, but it's pretty much lost everywhere else in the country. We've seen explosive growth in both vaxxed countries and unvaxxed countries. In particular, we've seen explosive growth in areas which had low levels of vaccination, like Louisiana, Florida, Arkansas, and the US. But we have also seen explosive growth here in Hawaii, where we have 60% of our population vaccinated. So vaccines alone are not stopping the Delta growth. Okay. In countries that do not have much vaccination and that have very effectively controlled the virus in the last year with masking, with distancing, with social interventions, basically we are now seeing explosive growth of the epidemic. So Delta really is spreading explosively around the world. Now, you say the vaccines prevented infections, reduced viral load and breakthroughs, and cut pre-Delta transmission in half. How did Delta change the game? Well, our understanding of Delta comes largely from data in China. Okay, they did an incredible study in Guangdong where there was an introduction of Delta in May, and the last case was stamped out in June. Okay, and this is the entire infection tree that they saw. They did contract tracing and they found 167 infections. They sequenced about 126 of those, and they reconstructed the infection chain. They then studied these people. They found two really important features of Delta here. First, it multiplies more quickly after infection. So basically, this is the time from infection to your first positive test. In the 2021 epidemic, which is Delta, that happens very quickly. And so the average time has dropped to about 4 days from time of infection to first positive test, whereas about 6 days with the previous virus, the outbreak in 2020, which was more the Wuhan type strains. Okay, so it's growing more quickly in the body and spreading more quickly. It is also producing much higher viral loads. Okay, this is cycle count again. You will notice the cycle count for the old outbreak, which is the blue here, is much higher than it is for Delta. Okay, in other words, Delta has lower cycle counts, which means it's more infectious. Okay, so it can spread more easily from one person to the other. And if we translate these cycle counts into viral loads, Delta is about 1,000 times the viral load of Alpha, or not of Alpha, sorry, of the wild type here. And what they found was that even if you were vaccinated, because you're starting from a higher viral load, you still get more infectiousness. And so, for example, this is the actual detailed tracing of an outbreak at 3 health centers in India. And these show you the cycle counts. These are nurses who basically got infected, even though the ones with dark blue here are all vaccinated, and look at their cycle counts: 15, 17, 13. Any cycle count above 20 means somebody is very, very infectious. Okay, so fundamentally, we were seeing high cycle counts even in people who were vaccinated. And this Indian data is some of the first that showed this very clearly. So what's happened? Delta has changed the game. We went from the original old wild type virus here that had an R0 of about 2.7. We then got to Alpha, which had an R0 somewhere around 4, 4.5. And now Delta has an R0, that is the number of people get infected in the absence of all interventions, up closer to 6 to 8. Okay, probably somewhere around 7-ish. Okay, that makes it as infectious as chickenpox. So it's a much more infectious virus than we dealt with before. Now, the other problem is this line is the percentage of people that we basically need to get covered in order to have herd immunity. Delta basically makes herd immunity practically impossible with the vaccines that exist right now. And even in our heavily vaxxed Hawaii, we have seen this explosive growth of Delta, which is also being accompanied by an exponential growth in the number of hospitalizations. This is actually the latest data from today, which was 655 infections here in Hawaii. Now, the contact tracing in Singapore also gave us some other disturbing features of Delta. The green here are people who are fully vaxxed, the yellow are partially vaxxed, the gray are unvaxxed. You can see many of the infections in this outbreak basically are among vaccinated people. We also see vaccinated people infecting other vaccinated people in super spreader events. This person infected 7 or 8 other people. This person infects another 6 people. And to make it worse, these red dots mean that it was an asymptomatic transmission. So this person was asymptomatic when they transmitted to that person. Okay, and over here in this other super spreader event, we see a large proportion of people up in the upper right-hand side of the screen. This person was asymptomatic and was transmitting to everybody else. Okay, so asymptomatic vaccinated people can infect others. CDC discovered this just a couple of days ago. Why were these vaccinated people transmitting Delta? Well, this is a study from Singapore, and it shows the cycle count, again, a measure of viral load, over time in the unvaccinated, red, and the vaccinated. For the first 4 to 5 days after you get infected, the vaccinated and unvaccinated have almost the same viral load, which basically means they are probably transmitted at about the same rates. The vaccinated, then their secondary immune response kicks in, their viral loads come down very quickly. So they're probably only infectious for a shorter period of time, but the unvaccinated will be infectious for a much longer period of time. Basically, until this CT value gets well below 30, they could potentially infect others. Okay. CDC found a similar thing in their outbreak in Provincetown, which they announced just last week. And fundamentally, again, same levels here. Now, the problem is we are seeing more reports of vaccine breakthroughs coming from other countries. Okay, so we're seeing, for example, Israel initially reported 64%, Singapore reported 69%. Israel then dropped it to 39%. England just Monday of this week announced 50% protection from vaccines. So the vaccines are turning out to be less effective against Delta. Now, the Israel data, which is probably the best data we have so far, was one of the lowest at 39%. But again, it's still being very protective against hospitalization and illness, still up in the 90% levels. Okay, so the vaccines are still working against hospitalization and illness. They're not working so well against transmission. And this slide shows that what they are concerned about, this is the time when the person received their second dose of vaccine. So January all the way out through April. And what we see is the earliest cases actually have lower protection. So we are concerned that the vaccines are waning over time. And this is why you're seeing a lot of talk of boosters. Pfizer published this that shows that if you get a booster, basically you will end up with a much higher level of protection than you will if you don't. Now, there may also be more severe disease with Delta. That is, it causes higher rates of death and hospitalization. And children are definitely susceptible to Delta. They've played a big role here in the UK. You can see some of the highest rates are in children 10 to 14 and 15 to 19. So the bottom line on Delta, it's much more infectious than previous variants. It increases breakthrough infections in vaccinated people. There's no question vaccinated people can spread Delta regardless of symptoms, and some can be super spreaders. And boosters are likely to be needed probably in the next 3 to 4 months for those who receive their vaccines fairly early. Now, what are the implications of this for the new normal? And bear with me, I'm going to run a little bit over to cover this, but it's important material. Well, the first thing we need to understand is what modeling studies were showing us even pre-Delta was that we needed not only vaccines, but we needed to maintain our masking, our distancing, our non-pharmaceutical interventions, even once we got a good rollout of the vaccines, because the vaccines are not 100% effective. And so there will be some ongoing transmission. Delta has changed the game even worse, okay? And I'm just going to jump to the approaches that we basically need to take to address these problems. First of all, I think it's necessary to acknowledge that we are in this together as a globe. We can no longer keep thinking about our responses as if it's a response of individual nations. We need much more rapid, efficient, and radically improved surveillance and ongoing synthesis of data that becomes available. We need both global and national tracking that includes tracking the variants, so-called genomic surveillance. We cannot rely only on data from our own countries. We knew just about everything we needed to know about Delta 2.5 months ago. But in the United States, we ignored it because we didn't have data here in the US because it was relatively low in the US. We ignored the data coming from the UK, coming from Singapore. That was a huge mistake. We really need to look at the data on a global scale. We need to rapidly characterize any new variant has the potential to spread rapidly. And we need to link this then to rapid development of new vaccines and additional testing to basically get it rolled out as quickly as possible. We need to expand the vaccine production capacity. Until we basically stop the spread of these viruses on a global scale, we will see new variants continue to roll out. And so the fact that only 23% of the world has even one shot of vaccine at this point means there's ample breeding ground for new variants. And in fact, Tony Fauci was on CNN this morning telling you, worry about new variants, they're coming. We have seen 4 basically changeovers in the virus in the first 1.5 years. Okay, the 4 different strains I described in this particular presentation. We need to lift the intellectual property protections now and share the production technologies. It's not enough for the entire world to depend on a handful of countries producing most of their vaccines. Every country needs to have its own ability to produce vaccines for its own people. And that way we can hope that if a new vaccine becomes necessary, we can roll it out on a global scale in months instead of our current trajectory when we will finish vaccinating the last person probably in like 2023 or something like this. So that will give the virus another 1.5 years at least basically to continue to spread and to develop new variants. We need to develop Manhattan-style projects for development of new technologies like cross-coronavirus vaccines. There are new vaccines being developed now that will protect against a large number of different variants and different types of coronaviruses. We need to expand that and accelerate that rapidly. We need to move to easier ways of distributing them instead of injection, maybe orals and sprays. And there is some work here, but again, it's sort of fringe efforts at this point, and we really need to put a lot more resources into that. And we need to improve our prophylaxis and treatments so that basically we can stop the infection if somebody is around somebody who's already contracted an infection, and also to treat those who basically develop illness. We do need to use vaccine certificates and mandates. Fortunately, the US seems to finally be coming around, but literally only in the last 2 days. We need to work on improvements in our masking technology. We need to accept it's no longer going to be vaccines or a mask. From now on, it has to be vaccines and mask. And we need to improve that masking technology to make sure we've got standards, that we have better masks that people can use for an extended period of time, and we need to educate the public more about the importance of masking. We also need especially to develop new strategies to address and to quash disinformation. Disinformation is largely responsible for virtually every COVID death that occurs in this country right now, because it's the disinformation that has kept many people from getting vaccinated. And that is resulting in the people we are seeing in Louisiana, in Missouri, who are basically overwhelming the hospitals at that point, and many of them are dying. We need to rein in the false media narratives and social media. And finally, I think it's really critical, we need some good social science research on rebuilding societal cohesion. We basically have become a divided society, and that has definitely stood in the way of our response to COVID in the last year and a half, and it makes it very difficult even to respond appropriately now. We're still seeing political divisions affecting public health decisions. That should not be happening. So we really do need social science researchers to spend more time looking at this and coming up with ways basically of addressing these issues. Now, I'm going to close with telling you something you probably don't want to hear. When will this pandemic be over? It ain't going to be the end of this year. It probably ain't going to be the end of next year. Honest truth, we are in a long haul with COVID. We are probably looking at least another 2 to 3 years of dealing with this, unless we develop a much more cohesive global strategy that deals with it. And people have pointed out no country is safe until every country is safe. That is absolutely true. Because if we leave one country out, that may be where the next variant that breaks through our vaccines very easily comes from. Herd immunity at this point is probably unattainable. Delta is just too infectious, and even if you vaccinated everybody with the vaccines we have right now, you would still see Delta spread. And there will be new variants coming out. So fundamentally, anybody who tells you when the COVID epidemic is going to end is really a fool. Okay, don't believe them. And I'm going to close on a few words that a friend of mine sent me in an email just must have been about a month ago now. He said, the desire to be done with the pandemic affects the judgment of people and most disastrously the decision makers. Wishing it to be near the end doesn't make it so. How many times do we have to repeat the same mistakes? On the downslope of the waves, go slow lifting viral restraints, quickly reapply at the first signs of recurring waves, and don't ever turn your back on the ocean or underestimate its force. That's from my friend Chad Meyer, who basically lives in Hana and is dealing with this issue on Maui as we speak. Okay, and with that, I will turn it back to Jill.
Tim, thank you so much for that eye-opening and informative presentation. We have a lot of questions for you, and we want to respect the time. So let's take our first question that our team's feeding us here. Let's see. What is the prevalence of the California Epsilon variant here?
California variants, they were actually fairly dominant early on in the Hawaii epidemic. Not surprising, so many of our tourists come from California. But basically, Delta has forced them out at this point. The last vaccine variant report that just came out yesterday, in fact, basically, I believe, had about 81% Delta in Hawaii now. So Delta really has overtaken, and the reasons are obvious. If you look at the graph I showed basically of the rocketing, I mean, literally skyrocketing infections that we're seeing here in Hawaii, that's all Delta. Delta is the only thing that is that infectious, and that's what's producing that. So It's really all Delta now, and both the New York and the California variants pretty much have been forced out at this point. They're still around probably in 1 or 2% levels.
Thank you. And can you address the vaccine hesitance concerns about the long-term risks of vaccines, particularly the messenger RNA vaccines?
I think the problem is people don't understand how these vaccines work. Okay, what they do is they deliver some snippets of so-called messenger RNA into your cells. And what they do is they instruct your cells to produce some spikes that are basically the same spikes that the virus produces on their surface. Your immune system then sees those spikes and moves in to basically kill those cells. Okay. And in the process, it also basically learns about the spike and develops antibodies that will protect you in the future against that. But basically, once that initial dose of mRNA is gone, no more. And so basically, and those cells, most of them were probably killed actually by the immune system in the early stages because they were seen as foreigners. Okay, but they educated the immune system about what's going on there. So there's nothing left. It does not integrate itself into your genome. It basically does nothing of that sort. The same is true of the adenovirus vaccines, like the AstraZeneca vaccine. What it does is it uses another virus to deliver the spikes to your cell. But that other virus is not able to reproduce itself. So again, it dies out very, very quickly. Your body cleans it out very quickly. So no, these do not leave things lingering around afterwards. So I think part of the problem we're facing, and again, this is disinformation. There are plenty of people out there, including this one osteopath out of Florida, who basically are telling people that, oh, it integrates into your genome, it changes you, it does all this sort of stuff. That's total garbage. It shows no understanding of the biology involved here. And it's the type of disinformation that I'm talking about. We need to have strategies to address and basically get it off the air because it's dangerous. It's killing people.
Absolutely. Thank you. And the next question, what is your advice on travel? Should pre-travel COVID tests be mandated for vaccinated travelers entering the state of Hawaii? Do you advise against canceling upcoming travel plans for those traveling in the coming days and weeks?
I'll put it this way. I personally wouldn't be getting on an airplane anytime soon. Delta is that contagious. Even if people are masked on the airplane, if they're not using good quality masks or they're taking them off to eat and drink, there's going to be Delta all over the cabin. And again, masks work very well if you use them properly. Although with Delta, I would even be recommending that you double mask or consider moving to N95 masks, which are available now. They're not just restricted to medical workers anymore. You can now find them again on Amazon, for example. So no, I would not be traveling. I would recommend against that. I mean, I certainly don't think it would be a bad idea to put a pre-travel test in. But given what I just showed you about how quickly Delta grows within the body, basically on average, 4 days before your first positive test, that means you could get infected after that 72 hours and basically still have it. So even if you tested negative at that point, you might still have Delta. So now if you're vaccinated, you'll only spread for 4 or 5 days instead of spreading for 3 weeks. Okay, so that's a good thing. But it still means, yes, the vaccinated can spread. And this is where I would really warn people, even if you are vaccinated, wear your mask to protect your family, to protect your children who can't be vaccinated. Wear a mask whenever you're outside of your home and get a good mask. Start double masking or get some N95s because that's really critical with this contagious virus.
I guess it's safe to say, Tim, that you would probably not be eating at restaurants at this time too.
I will not go near restaurants. The ventilation in restaurants is generally comparatively poor. People are taking their mask off to eat, which means they are spreading Delta all over the place, quite frankly, if they're infected. And as we've seen, both the vaccinated and the unvaccinated can be spreading Delta. So even if you go into a restaurant where everybody is vaccinated, there's no guarantee you won't be exposed. And honestly, we are seeing far too many supercluster outbreaks among vaccinated people. They're showing up in the media every day. I showed you them in Singapore in the early stages of the epidemic. That was back in like April. We were seeing those types of super spreader events among vaccinated people in Singapore. So absolutely wear your mask. And I would really recommend against eating in restaurants at this point. Do takeout. Support your restaurants, do takeout.
I agree. Okay, next question. What can you tell us about the Lambda variant? Should we be concerned, or is it too early to tell based on the data? Are there any emerging variants that we should be concerned about?
Right now, Lambda has been a significant player in South America, where in countries like Chile and so on, it basically has taken over. But it doesn't seem to have grown in countries outside of that region for some reason. Whether it's just that it's being delayed in getting there, maybe they're less connected to the rest of the world than other countries are. Uh, but there are some concerns that it may cause more serious illness, and in particular, more serious illness among children. But again, it's not very well characterized at this point. And this is where I was saying we really need a global effort to characterize these variants very, very quickly, regardless of where the data is coming from. I think the problem we have, and we've seen this in the United States, is countries tend to focus only on data that comes from their country, which means we ignored Delta. We honestly ignored Delta in 2 weeks ago, literally. 2 weeks ago was the first time I saw Delta mentioned on the news. I have been watching Delta for 3 months, looking at the data from the UK and from Singapore, and I have known what was coming. I've been watching this train wreck come. Okay. And so if we were making use of the data from other countries the way we should be, we would have known about this, and CDC should have been prepared for this, quite frankly. The data was all on the table and was fully available to anybody who wanted to find it and read it. So yes, we do need to characterize them more. Right now, there are no variants that we know we have to worry about, but that doesn't mean that won't change tomorrow.
So Tim, today, our mayor said in a press conference that he has no intent in imposing mitigation measures because Hawaii now has critical mass of vaccinated people. Can you explicitly review this stance?
Not in polite company. Fundamentally, it's idiotic at this point. We had 655 new cases of Delta today, basically.
Mm-hmm.
That is double what we had yesterday. We are in a rapid exponential rise. To not impose mitigation measures at this point is the height of idiocy. And you can quote me on that. It makes no sense whatsoever. It's not a public health stance.
Thank you, Tim. And with these record-breaking numbers that we've seen today, what are your thoughts about our school-age children going back to school this week with already overcrowded classrooms and poor ventilation? Will masking be enough to protect them? And what's your stance on that?
Again, I personally have serious questions. If I had kids, I would not be sending them to school right now. I don't have any kids. I only have a small dog, but the dog doesn't go to school, not anymore. But fundamentally, no, I would not be sending my kids to school. I think that while, there is some plan in place, it was finally published only toward the end of last week. I don't believe they've had adequate time probably to put all the measures in place that they need in place. Dr. Char can check me on this or so on if she knows better. But again, if I were a parent, until I saw some proof that the schools had been made safe and that there wasn't likely to be massive transmission there, I would be very hesitant to send a child to school at this point. You got to remember, 135,000 of those children are unvaccinated right now. Yes, there are about 180,000 of them, but 135,000 are unvaccinated. So you're basically going into an unvaccinated population there.
So we need to cut this event short so I can go and get my son from school right now. So just, being aware of the time, we have about 5 more minutes left. I know, Tim, that you said you'd stick around a little bit just to make sure that we can answer all the questions that you can. So to our attendees, thank you for sticking around with us, but we do have a few more questions that we'll cover. From one of our attendees, he has heard that the governor has cited the low number of case counts classified by the Department of Health contact tracers as travel associated. Does the Department of Health contact tracing data regarding travel associated cases provide a useful, I'm sorry, wait, my team's actually typing the questions live and the words are moving, so please bear with me here. Does the DOH contact tracing data regarding travel associated cases provide a useful or misleading picture for determining travel policy?
I think travel-related cases are really more a question of whether the virus finds fertile ground when it lands than whether one or two cases is introduced through travel. Now, if massive numbers of cases are coming in through travel, then yes, that's a concern. Although we have pre-travel testing at this point. We have a vaccine requirement now. So we are probably keeping that somewhat lower. But the question is, does the virus find fertile ground when it gets here to Hawaii? And we have the answer to that. The answer is 655 cases today. Yes, there is fertile ground here. The community transmission on Oahu right now, and all the islands. I mean, the Big Island is every bit as exponentially rising as is Maui, as is Oahu. So across the state, we basically have clearly fertile ground basically for transmission of the virus. So I'm not that worried about travel related right now. That we're past that point. Most of our transmission is indigenous. It basically is locally within our own population, and that's the real issue that we have to deal with here. And again, it's going to have to be vaccines and masking, not or, and.
And all right. Tim, this virus is invisible, and that contributes to such a high public indifference, especially among the youth. How do you feel this problem can be attacked?
I mean, it's a difficult one to address. And, while children do have, less serious illness generally, there are still children who die of this. There are, I forget the actual number, I think it's like 19 children who've been hospitalized, 0 to 17, in the last 2 weeks here in Hawaii. So children are being hospitalized with this. So it is not a harmless virus, even among children. It is invisible. And I mean, that's always the problem. But what we need to educate people is just that the virus is there in the community. And we basically need to deal with that.
Thank you. Let's see, our next question. Is it better to give a single dose of vaccination to a large population or gradually fully vaccinate a smaller population at a time?
With Delta at this point, it's very clear with our current vaccines, you get very little protection with a single dose. Even in the UK, basically the protection with single dose was only about 30%. So no, double dose is what works now. And basically, distance, lock yourself away if you can, work from home if you can. We honestly, given that we are in a far worse situation than we were last year, people should be doing all the same things that we were doing last year to protect themselves.
Mm-hmm. Great. And I think this is our last question. Does Hawaii have the ability to sequence a substantial proportion of the COVID cases to monitor for current and emerging variants?
I personally don't think we sequence enough. I think there's a whole lot of additional sequencing that's needed here. And basically there should be resources available. CDC received I think over $1 billion basically for expanding sequencing capacity on a national scale. So there should be resources there. And honestly, I think we need to go after them and get them.
Great. Well, Tim, thank you so much for sharing your time and expertise with us today, and mostly for your ongoing efforts to keep our community safe and informed. Mahalo to all of you, our attendees that joined us today, and special thanks to our East West Center's Communications and External Relations team for coordinating this event. Please join us at our next EWC Insights Counting Women's Work on Wednesday, August 18th, featuring Dr. Gretchen Donauer. This webinar is part of our Asia Pacific Demographic Transition Series, and you can register now at eastwestcenter.org/events. Just a reminder that a recording of today's webinar will be available for viewing on EWC's YouTube channel. Again, mahalo for joining us today, and stay safe out there. Aloha.